we're going into a panel, and we want to talk about universal health coverage. We keep talking. I was head of UHC. We keep talking about UHC. It's one of those common terms right now in most high-level gatherings where health is being discussed. So we're going to talk about universal health coverage, a roadmap towards inclusive healthcare systems. So to join me on this podium, we already have Dr. Ishak Lawal here. Dr. Ishak Lawal is the Executive Director of End Cervical Cancer Nigeria Initiative. Can we please give him a round of applause? He's worked endlessly to make sure we have the HPV vaccine that we presently are giving to girls between 9 and 13 years. So also, Raihanah Ibrahim, is she in the building? Can we please give her a round of applause as she comes? Let's not stop clapping. Raihanah Ibrahim, she's a principal at Solina, Center for International Development and Research. Just come up. You're welcome, Raihanah. We also have Jonathan Eigege, who is the associate partner at Albright's Stonebridge Group, African Practice. You're welcome, Jonathan. We have Dr. Mories Atoki. She's online. Hi, Dr. Atoki. And last but not least, we have Mr. Afeez Olajire, who is the managing partner at A Strategy and Consults Limited. Please, let's give him a round of applause, please. So, thank you very much. We know what universal health coverage is, maybe for our audience. So universal health coverage just means that all people have access to full range of quality health services they need, when and where they need them. It's not about ultra-modern hospital structures. It's about access and availability. There have been a lot of conversations since 2019. So towards the end of the MDGs, it was discovered that determinants of health were impacting health more than other factors. So when it was for the SDGs, UHC has been picked, and it's a very important thing, and WHO is giving strategies through optimizing primary health care, because they believe that primary health care is an easy way to get to UHC in Africa or the low and medium income countries. So to start off this discussion, I'll start with Mr. Olajire. What's your take, UHC in Nigeria?
Yeah, thanks, Dr. Cornelius. I think UHC in Nigeria, the goal is pretty straightforward. We are looking to achieve sustainable development goal, and that is more of working towards health for all. Irrespective of where you live, what you do, and how much you have, you should be able to have access to basic health care provision, like at the minimum. And in doing that, the thought is to be implementing that through the primary health care structure. We assume that should be the most accessible for everyone, both the vulnerable group and people that live in the urban area. So UHCs get healthcare service to the last person and ensure it's as accessible as possible at the least affordable cost.
Thank you very much, Mr. Olajire, on that. I want to hear from Dr. Lawal. Dr. Lawal, as someone who is a frontline practitioner, how do you look at the impact of governance on universal health coverage and access to care for your patients?
It's first, when we define the UHC, there's an important component about it which says without suffering financial hardship. And so that is where it gets tricky. So it's not just the government, because if you want to restrict it to government, sadly, in almost every facet of our life that we'll look at, the government has scored very low. And therefore, it has to be a collaborative effort. But sadly, is that even the small activities that the government has done, stakeholders have not allowed success, for example. For example, stakeholders in cancer, because I'm a cancer advocate, and that's where my interest is always about. And truth about it is, we cannot achieve universal health coverage without achieving care for cancer care without suffering financial toxicity. And by financial toxicity, we are talking about financial hardship. So, government of Muhammad Buhari made what we call Cancer Health Fund about over 2-3 years. About close to $1 billion was accrued into that fund. And somebody was waiting for formal flag off before patients start assessing fund. I mean, so till now, we don't even know how that fund is being spent. So in terms of governance, there is some positive move, particularly in terms of the National Health Insurance Scheme, when they now say that the National Insurance Scheme should, there's a compulsory, it's now National Health Insurance Act. So the transition to National Health Insurance Act and making it compulsory sounds good, but it's still in theory. The gaps, the reality is still very far. So I would just say that it's a collective responsibility. We should not keep quiet. And hopefully, you do your bit, I do my bit, government does this bit, we will get there.
Thank you very much, Dr. Lawal. Please, can you give him a round of applause? Jonathan, looking at you, you look like a politician. So that's why I'm going to ask you this question. So it's about the political economy. So we know there's a political economy of health in Nigeria. The Abuja Declaration of 2001 says government should contribute 15%, and we have not done that, despite the fact that it was declared in Abuja. It's called the Abuja Declaration. But the Abuja Declaration in Nigeria has not been followed. In your opinion, what strategies do you think will be implemented to transform the political economy for health so that we have this sustained political will and increased government spending?
Yeah, thanks for that question. I should say I'm not a politician, or I beg. I'm just a consultant, but a consultant who works with a lot of politicians. And, you know, being able to sort of be in the room, you know, one of the things I remember being early in my career, and, you know, I was one of those people who thought that our politicians didn't know what to do or did not prioritize primary health care or development or a lot of things that the people in this room care about. But being in the room, you see that they actually do. There's just no incentive to prioritize a lot of those things. And that's where the political economy comes in, right? And so in thinking about how, you know, like you rightly said, there's the Abuja Declaration, which calls for at least 15% of the budget to flow to healthcare. And that's federal and state, by the way, not just federal, because I think sometimes, even in our advocacy, we're focused on the federal level, but service delivery is actually a state thing, right? So, but you know, on average, I think over the past 10 years or so, Nigeria has averaged only about 5% of our budget flowing to healthcare, which is only about a third of the Abuja Declaration, right? But in thinking about how we shift that political economy and get people to care, I like to think of the 3 Ps of political economy. So the first one is people. So at the end of the day, it comes down to us as a collective and what demands we're making of our leaders, how we're holding them accountable, and using the power that we have, right, as citizens and as voters to, speaking with our votes, essentially, and asking them to be accountable to sort of the promises that they've made. The second one is personalities, and I think in a market like Nigeria, this is actually maybe the most important one. The people who we elect and the people who are in positions of power have significant influence over where funds flow, what policies are prioritized. And we're in a really great position now, right, because we're in the 6-month window after an election and a transition in power, and we have some great personalities who are champions and allies who we can call on to drive financing for women's health. So the Honorable Minister of Health, Minister Pate, is one of them. Dr. Salma, who currently advises the President on health. But also, for the first time in Nigeria, we have about 9 commissioners of health who are women, right? So how do we leverage those women champions that we have, but then also identify male champions who can help amplify some of that advocacy? And then the last piece, and I think this is a really important one, is just narrative and our messaging, or as we like to call it in Nigeria, packaging, right? So what messages are you sending? And so I think having, especially as advocates, some dose of reality about what is possible, and also taking a long view with our advocacy, not always being idealistic, but sort of couching it in reality. So for example, if you're advocating for family planning, for example, a rights-based approach or argument may not work in certain parts of the country, but if you start to make the economic case for family planning, and think about the fact that in a fiscally stressed country like Nigeria's government is thinking about how to make dollars go further, then you start to make cases like the fact that there's in some cases up to a 16% return on every dollar, or a $16 return on every dollar spent on family planning. Then those messages start to resonate. So we'll just focus on people, personalities, and packaging.
Thank you very much, Jonathan. Over to you now, Raihanah. For Nigeria, we're still having issues around infectious disease. The world, right now, most of the world is moving towards non-communicable diseases. But here we're still grappling with Lassa fever, we still got the monkeypox. COVID isn't over. We still have issues around human resource for healthcare. So what's your take, UHC? Do you think we can get there?
Absolutely. I think the reason I wake up every day is because I know that we can get there. That's why we wake up and we show up and try to solve the problems. And most of the time, I think you've asked the question around governance, and the answers we got are very clear. That's really the bedrock of what determines where we're going and how we'll get there and if we'll get there. Because it goes all the way from the right priorities that we're setting. And he mentioned something around, are people really incentivized to prioritize universal health care? I mean, as a governor, do you want to build roads so you can get reelected, or do you want to put those millions in maternal health care and save women's lives who are dying from childbirth? Many of the times, the prioritization is really that simple. It's, what exactly is driving the people making the decisions, and what do they think they'll get out of it? So there is prioritization and setting the right priorities and knowing what the right priorities should be. I think there's the second element, which is participation. As a governor, what are you really doing? As a commissioner, what are you doing to make sure that you're actually looking in and you're taking the decisions that you need to take? And when the tough decisions come around accountability, how are we making them? So if we say we don't have human resources for health, of course there are many layers to that and many complications, but have we really first decided we want to solve the problem, to be intentional and very clear and all come together to be true to that commitment? And then how do we pool all of the resources together to make it happen? I think there's a lot of money that goes into healthcare, and like he said, government alone cannot do it, right? So there's partners doing things, there's banks that are bringing resources together, only that we're not pooling everything in one place to have a coordinated response. So with COVID, we've seen that we can do a number of things and we can do those things fast. It's really what is our motivation, how are we collaborating, and ultimately, how do we channel those resources? And to be clear, it's very hard, rigorous, dirty work that will take a lot to get there, but we do believe we can get there, and I believe that's why we're here sitting to talk about it.
Thank you very much, Raihanah. Do we still have Dr. Mories online? Okay. Can you hear us?
I can hear you loud and clear. Can you hear me?
Yeah, loud and clear too. So, what do stakeholders like me and you, what can we do to make people know that we have the numbers, healthcare is business, and with the numbers, we can make UHC work if we are not concentrating on building structures? What's your take, UHC in Nigeria?
Right, thank you so much. And thanks to PIC for having me. I've also been listening to the previous panelists. Thank you for sharing those very important insights. I particularly want to start with Dr. Lawal's contributions, and is to really appreciate what medical practitioners have to face on the field, and the reality of what we are saddled with as a nation and as a continent. I think it's imperative that we consider our realities more pertinently. I'm not sure as a nation we're doing that enough. And the reality is that, you see, so now the mantra is that government is not able to do it alone. And I mean, fair enough, I mean, in my organization as well, that's usually what we start with. But each time I reflect, you know, it looks like we've gotten so used to that mantra that now even government is feeling comfortable in the sense that we have accepted that it is no longer the responsibility of government to provide public health, and that's majorly through the primary health care, whereas it still is. We're responding as stakeholders to the failures of government, and so that we don't play the blame game, we're choosing our words. But that's, again, worries me as a stakeholder, Mr. Moderator, as you asked. And for me, there are two components to all of this. I'll talk about where I think the health community needs to reconsider and maybe wear a different lens to arrive at a more customized approach. Is the fact that things have radically changed over the last 2 decades. Yes, government has not set their priorities right. There's been a lot of neglect for primary health care, which, by the way, is about 70% of the health that you people like you and I, Mr. Moderator, actually seek after, and that's enormous. And if we say that, what we're also saying is that this category of healthcare, if consistently neglected, leaves us no chance than to look at other key stakeholders who support the failed health system. Remember, it's primarily the responsibility of government. But now that we are in a case where we are in, we look up to the likes of the private sector. And this takes me to the second component, is the fact that the health community is no longer supported as ought to be by government or international partners. Investors from the private sector are beginning to look at the health sector. So when we say health as a business, those are the kind of thinkings we're about. But you see, the language, the structure, the models are clearly different from what an average medical doctor was taught before he became a medical doctor, or an health entrepreneur before he became a health entrepreneur. So we need to fundamentally revisit the learnings and the teachings and what doctors are used to. So for instance, we find out, for example, from where I sit, we did a forum where we invited investors from all over the world, and we grouped a couple of experienced, existing health entrepreneurs. But we could see that they couldn't connect with the investors. You know, the languages were not correct. I'm from the private sector, so again, I know what it is like if you want an investor on board. The languages were not correct. There was a little bit of, you know, I mean, technically they weren't ready, in a nutshell. And I think Nigeria as a nation have to move deliberately away from that. We need to make deliberate efforts to ensure that people in the health sector, especially drivers of health entrepreneurship, need to know how to build capacity to be able to attract the right set of investors. Health generally doesn't appear, again, I mean, if you're looking at a country like Nigeria, where about 98% are living in extreme poverty, you would worry where the profits are going to come from. But again, for people who are really business people, who are able to tell about the numbers, you know, from a bird's eye view, and are able to do the mathematics to be able to arrive at potential profit, then you need to talk real business to them. And these are not business structures that you learn ideally in medical school. So for me, there's a whole lot of dimensions going on that we need to, first of all, understand our realities. Second, address it at fundamental levels, at academic, you know, levels, as well as at practical levels, and to be able to move forward and address universal health coverage for Nigeria as a whole. Thank you very much.
Thank you very much. Okay, please let's give her a round of applause. We have been able to unveil what the problems are. In 1 minute, I'll just ask us, because we have like 7 minutes more. In a minute, let's talk some solutions, innovative solutions. Afeez, in your opinion, what can NHIE do innovatively so we leave that 4%, because the coverage is 4% of 200 million people. So, innovatively.
Yeah, thanks, Dr. Cornelius. So I think what we need to do is straightforward. And at least in a country like Nigeria, where we have cracked a lot of bigger problems, we have suboptimal enrollment of people on the NHIE and SHIE scheme. That's the first problem. Then the second is that even for one we enroll we should enroll them, but if we're talking about equitable coverage, we should be enrolling all this informal sector, because most of the time they are the ones that could not access this health care. So what do we need to do? There is a way we get election material to them when we want them to vote, right? And we need to, first thing first, we need to build our confidence in the primary health care system. If everyone is sure that if I get to that PAC in my community, I'm going to get quality health care, for sure they will want to enroll. Because if I'm telling a market woman to put her money to pay for premium for health insurance, she won't mind paying, as long as she's sure she's going to get good health care. So now to the innovation that we need to do. We've seen a lot of effort in ensuring that we have digital money when we need to improve financing, all these POS services and all of that. We have that. We have a way of making people load recharge card even when they are at the last mile. So if the problem is how do we get them to pay the premium, let's digitalize the payment for SHIA at the state level. Let's work with the head of the market group or an artisan group and bring them on board. But for us to actually convince anyone to come on board to health insurance, I think the first and the most important thing is to build their confidence in the healthcare that they are going to access. Once that is fixed, every other thing happens naturally. People will pay for his service as long as they are sure they will get value for their money. Yeah.
Thank you very much, Afeez. Jonathan, political economy. What is the need for the politician? Because the guy is concerned about the next 4 years. What do I have to tell him to make him increase investment in health? You have 1 minute.
Yeah, no, I don't think 1 minute is enough, right? But I think it's a tough sell. The honest truth is that it's a tough sell, especially in a market like Nigeria, where, the truth is we vote with our stomachs because of sort of the state of the economy, right? So it's harder to sell sort of grand visions, and especially to sell the legacy argument to politicians. But you know what I think what we are seeing is working is actually competition. Right, so governors hate it when you tell another governor that they're doing, or you sort of, at the Nigerian Governors Forum, you say, this your peer is doing so much better than you. So just leveraging that friendly competition, leveraging platforms like the National Economic Council, Nigerian Governors Forum, and actually making sure that the accountability works, right? Because if we don't have scorecards, we can't compare, right? So I would say competition is a good way, but then also finding exemplars, right, and really partnering with them to make them exemplars who their peers can follow.
Thank you very much. Dr. Ishak Lawal, these patients don't come until they want to die. And many times it's because they have tried other things. We have issues around AMR. They've taken all the antibiotics before they come to you. And how do I get them to access care? Part of the problem is access. They just want to get to the pharmacy because they know when they come to you, they're going to spend 3 hours before they see you. How do I encourage the patients to come to the clinic?
Well, for the shortness of time, I will just say that my experience is that it's not true that the patient don't come early. A lot of times, patient resort to alternative care because they've come and we have failed them because they cannot afford it. And then they will not say, rather than going home and dying, they will then say they take the one that is easier for them, prayer, traditional home, and all that. But, so just to say that for the want of time. However, I want to quickly make one or two other submissions. You talked about increasing funding. For me, when you talk about, there are two perspectives when you talk about funding. One, how judicious are we using the one we have? So the first thing is we must hold the system accountable, as he said, because if there's no accountability, you increase the funding into the open basket and it just go down the drain. So we need a system of accountability. You ask, what should stakeholders do? We should hold the government responsible. We should find a way to hold them accountable to us. And everything we are trying to do to improve the health system, if you don't address this issue of JAPA, it must sound funny. There are hospitals, even teaching hospitals are not having doctors. We are talking about primary health care. On a daily basis, doctors are entering Saudi. As I'm talking to you now, God bless my wife. She's the one sustaining us because she's in Saudi. That's the truth.
So that's why you have not left.
Thank you.
What can private sector do from initiative perspective? How can we support institutions like the NHIs to deliver?
Okay. I think the private sector has a key role to play in universal healthcare, right? Like she said, a lot of people resort to private sector as that mechanism to fill the gaps that the public sector cannot quite match. And to do that, and this was pretty interesting in some experience we've done implementing routine, like HIV services or immunization programs in private sector, which is helping to reach those places. There are a lot of private health facilities, for example, that deliver services that, it's actually a responsibility of the primary health care in the government sector. But bringing private health facilities and private service providers, PPMVs, community pharmacies, community labs, to expand access, especially to people who are marginalized in hard-to-reach areas in urban slums, is one of those ways. However, there is a broader conversation around private sector and resource mobilization, whether that is human resources, whether that is financial resources, different models like trust funds where private sector pool monies together, or like we had with the coalition for COVID, where we had with COVID, where it was like private sector mobilizing resources. Of course, none of that is still possible. And private sector will always want to solve for what's the value for my money, and also what do I get in return. So it won't always be free, right? So a lot of innovation needs to come into how we think about how that works. But at the same time is going back to the accountability, which is how do you ensure that people can put their monies in healthcare and that they will get return on all of their investments. So that's one thing to crack.
Thank you very much. Dr. Mories, are you still there? Your closing words. We're out of time.
I worry when you ask.
Okay. In a minute, please. We're rounding off.
It's also a quick one, and it's really to charge every member of the health community to say that it's not the time to give in to the pressures of government and in a way send the wrong message to think a government has been, the responsibility and of accountability for primary health care has been taken off them, and so private sector is doing it and all of that. I think in the start of our conversations, and especially in sensitizing the public, which we must also be very aware that we are, messengers for the public as well, to understand some of these nuances. So for instance, a critical question was asked at a point in time by the moderator to Dr. Lawal, where does blood come from? And according to the event, he told us that there were 26 ladies from the nursing home. Meanwhile, really, in an ideal structure, the blood bank should actually be accessible enough to be able to receive the blood that the woman needed to survive. And I think holding our minds around the right things, the right structures in every conversation, so that the government representatives, the community itself, medical practitioners and non-medical practitioners, we remind ourselves at all times what the expectations are, and we're not giving in because of the pressures that we're saddled with as a society. Over.
Thank you very much. I don't have time for questions because we're out of time now. So thank you very much for listening to us. Thank you, panelists, for coming. It's been a pleasure. Thanks.